Hello everyone, this is Dr. Sanket Pisat and this is a post regarding one of the queries that was posted in one of our online discussion groups as regards management of suspicious adnexal mass. So the query that was asked by the doctor is that she has a patient who is 35 years old, a known case of endometriosis. She was on OC pills and suddenly the cyst, which was earlier 4 centimeters in size, has now become about 12 centimeters, and the CA125 is 75. So the question posed is, what are the possibilities of this becoming a malignant mass? USG shows a solid area in the cyst of size 3 centimeters, and though MRI was not done, and though the MRI was not done, let us assume for the same reason that as of now the MRI has been done, it is still showing a cyst with a solid area of 3 centimeters size, and there is no ascites and no nodes. So the poll that we had posted was to choose between one of 3 or 4 conditions. First, that there is no need for surgery at all, she can continue medical treatment, but that none of the people have chosen, and the opinion or the doubts are between these 3. So one option is lap oophorectomy with frozen section and SOS radical surgery if the mass turns out to be malignant. The other opinion given is open oophorectomy with frozen SOS radical surgery, and the third is only do lap oophorectomy and do not do a frozen and wait for the final HPE report. And the last option, of course, is do only open oophorectomy and wait for the HPE report. So the real choice is between deciding between these 3 scenarios and which one you would do for your specific patient if this was a case that you were managing. So let's try and take these things one by one. Sorry about that. Right. So let's take all 3 options one at a time. If you look at option 1, so what are the doubts that, or what are the issues at hand over here? First of all is the fact that the USG is showing a solid area. Then is the issue that the CA125 is not raised. Thirdly, the age of the patient, she's a young lady, so 35 years old, she's a young lady, and of course she may wish to have pregnancy, or in any case retain the uterus, if not for childbearing then for menstrual function. So whether we should actually go in for a cystectomy or for a oophorectomy. Now among all of these, let us say that we are going ahead with an oophorectomy. First of all, among all these 3 options that have been given to us, I think when we look at a patient in whom we have got, so we all know that there is an IOTA scoring system which is available. One of our readers has already posted a link to a very easy scoring system which can be utilized online, and I'm going to put that link up at the end of this video. But let's see what are the issues that we are dealing with at hand here. Suppose, let us take each option one by one, and so let's say we decide to go with option 1. What is the consideration actually between these 2 different things? One is, someone is saying that we're wanting to do lap oophorectomy, and there is another school of thought which is saying that they will do open oophorectomy. First of all, let us see the question, why oophorectomy and why not cystectomy? Why oophorectomy in this case? So I think when you have the information in front of you, we go a lot by the appearance of the cyst, the age of the patient, the CA125, the presence of nodes and ascites, CA125 or other markers, and nodes and ascites. So among all of these, I think the one which has the most importance, particularly in terms of appearance, is the presence of a solid area in the cyst. Once a solid area has been reported on MRI inside the cyst, The cyst has to be deemed malignant till proven otherwise, even if all of the other three do not suggest any malignancy at all. We have to consider that this cyst could be malignant, and therefore we are going ahead with the further management accordingly. So, once considering that this cyst is malignant, what are the options over here? If we do say that this cyst is malignant, then one, can we do a cystectomy? So we cannot. We may have considered even a cystectomy if the lady girl was very young and unmarried, but since she is 35 years old and has a child, there is no issue. I think it is safer to go ahead and remove the ovary or do an oophorectomy rather than do a cystectomy with a solid ovarian mass and find out later that it caused probably a borderline malignant, and then do an oophorectomy at a later date. So we will be unnecessarily doing a two-stage surgery for nothing. That dilemma may have come up if the patient did not have children, but with this history of her already having one child and being 35-year-old, I would go ahead with oophorectomy. So definitely I agree with the fact that oophorectomy has to be done, and I would not do cystectomy for this patient. Now comes question number 2. Question number 2 is whether one should attempt this laparoscopically or whether one should do this open. Now traditionally what has been told to us is that whenever we are doing surgery for an ovarian cyst, we try to not rupture the cyst, because rupturing the cyst will cause upstaging of the disease. That means if the disease is localized to the ovary, you will be upstaging the disease by rupturing the cyst inside, and hence the preference of most people for open surgery in this case. However, there is a problem over here. First of all, if there is the slightest suspicion that you have a strong case for a malignant mass, then I agree with the fact that you must go ahead with open surgery only. However, there is a slight dilemma here, and of course you could have a difference of opinion compared to what I'm saying here. But I think what happens with endometriotic cysts is whether you do open surgery or whether you do lap surgery, it is virtually impossible in either scenarios to remove the cyst intact. If it is an endometriotic cyst, come what may, the cyst is going to rupture inside, whether you do open or whether you do lap surgery. Now, given the fact that it is so, maybe if we change the scenario and we are talking of a dermoid cyst or a well encapsulated cystadenoma, then in that case I would be very keen to perform a vertical midline laparotomy incision or a fan and steel incision, take the cyst, the ovary out intact, clamp it and remove it without spillage. But here in this case, since we are talking of an endometrioma, the probability that you will be able to remove the whole thing intact in open surgery is very limited. So it is doubtful whether one would go for lap or whether one would go for open. But given the fact that it is going to rupture anyway, I would probably consider doing a lap oophorectomy. Now the question is, with lap oophorectomy, should one do frozen section or one should wait for the final HPE report? Now this again is debatable, and again you can put your comments in the comment section if you don't agree to what I say. I think there cannot be one single point of view that is correct in this case. But the thing is that with frozen section, we know that there is some margin of error. I really do not know how much margin of error. Maybe let us take it as 5%, 8%, or maybe 10% error. Going on the lower side, let's consider 5%. And we all know that when we get the report, you will either receive the report on table as non-malignant, it can be malignant, or you will get the report as borderline. In the first two scenarios, there is nothing much to talk about. So you know that what you're going to do in these two cases. The question is of this report, and many times if the pathologist is also not very sure of what they are doing, you get a non-committal report of the tissue being borderline. Now the question is, with a borderline and a 35-year-old, what would you like to do for this patient? Would you like to perform a complete panhysterectomy and removal of lymph nodes, etc., etc., for this case? And then what if in the final histopath report this borderline actually turns out to be non-malignant? So this is the dilemma that we are facing over here. Either you can counsel the patient and tell the patient that you will be performing a surgery which, in case it is borderline, we will be going ahead with the surgery, but you have to consider that there is a margin of error, and in case you are in the category where your surgery was done considering it is a borderline mass but it finally turned out to be a non-malignant mass, you will have had a full hysterectomy, lymph node dissection, and omentectomy, or whatever it is that needs to be done. All of it will have been in vain. The second option is that one can tell the patient that we will do a lap oophorectomy and we will wait for the final histopath report, because in doing that you are sure that the patient does or does not require a radical surgery. The patient, so there is definite surety of the report. The patient is mentally ready and financially ready as well. Given the fact that you are telling the patient there is a 5% risk of error in the frozen section report, it is going to be very difficult for the patient to digest or for the relatives to take a call on whether hysterectomy should be or should not be performed on table. So I think waiting for the final HPA report of course makes sense, but with the full understanding that this patient is by her own choice opting for a two-stage surgery. So I think it is worthwhile giving the patient that chance, that instead of going in radically and completing everything, we can directly go in for a two-stage surgery. By chance, if that solid area, so you also have to account for some error in radiology. Maybe that solid area isn't what the radiologist thought. It is very difficult to say. We are just going by. So if the solid area actually does turn out to be non-malignant, then we have saved the patient the trouble of doing an open surgery, and we have saved the trouble of her undergoing a radical surgery in the same sitting by choosing this particular option, lap oophorectomy, and waiting for the final HPA report. But then this also depends on the patient's outlook. If the patient says that it is only one stage surgery that is suitable for her, and she cannot accept the possibility of any upstaging happening, and whatever little protection can be given to her by means of open surgery, then it is fair enough that you consider open oophorectomy and you either combine it with frozen and opt for surgery in the same sitting, or you combine it with a final HPE and do surgery at a later sitting. So these are the possible treatment options available. Same thing I would lean on more and more on this side of the treatment. So this will be my choice of treatment in a younger patient, unless of course it is something which is definitively seen, like you also have multiple other things to suggest that it will be malignant and the cyst can be removed, the entire ovary can be removed without spillage, then probably my choice would then lean on open oophorectomy. But still, in a younger patient, I would still like to wait, personally at least, for the final HPE report and then only take a call, rather than having had done a panhysterectomy, lymph node removal, omentectomy in a patient who absolutely does not have a malignancy. So I think this is my choice of what I will do. I agree with these people who have voted, but this is a very debatable question. So the choice is entirely up to you. Do let me know in the comment section on YouTube or in the group what you feel like. So this is the online calculator model. This has been shared by our colleagues from Hong Kong, Dr. Winnie Young and Dr. Irene Horn. This is the link to the model. I think this is a free website, so anyone can access this using this link. So let's use it and see. The risk prediction of malignancy in ovarian cancer. As far as this patient is concerned, she is 35 years old, so I'm going to put that inside the box. Okay, so age 35 years. Then my center is not a dedicated tertiary referral center, so I'll put in no. Maximal diameter of the lesion is 12 centimeters, so 120. Maximal diameter of the largest solid part is 3 centimeters, so we'll go with 30 millimeters. Cyst locules, no loculation has been reported, so I'll take 0 to 10. Number of papillary projections, nothing like that has been reported, so we'll go with none. No acoustic shadowing reported, no ascites, and serum CA125 level is 75, so we'll take 75. And then this is the calculator that has come up, which says that the possibility of this being benign is 82.6% and 17.4% chance of malignancy with 5.2% chance of borderline. So in case that this patient would have been a patient who completed her fertility, I would definitely have leaned on going ahead with a frozen and radical surgery in the same sitting. But at 35 and only one child, I would still give her the benefit of doubt. But this is my outlook. You can put up whatever you think will be the correct way to go ahead in this particular case. Again, remember that all calculators may not be as accurate as we wish them to be. There is going to be a small margin of error, so finally you will have to decide based upon your own assessment of the patient, the situation, and a lot of other factors. So and that's it. For those of you who have not yet joined, please visit our website www.endogynetraining.com, where people post queries as regards daily life questions in gynae endoscopy, and we try to answer them by means of mutual discussion or by short lectures and videos whenever possible. So that's it. I think that's it for this video. Thank you so much, and thank you for listening.